welcome Professor Schuppan. We are very pleased to have you, and you will walk us through this presentation on development and the role of supportive medication for celiac disease. Thank you very much, and the floor is yours.
Yes, thank you very much, Veronica. I'm very glad to have a little talk at AOECS again. Unfortunately, I have to go to a liver meeting in San Diego and cannot attend, but I will give you a quick overview on novel pharmacological therapies for celiac disease. Okay. So these are no real COIs. I don't earn a lot of money with consultancy or something like that, or don't have any current patent shares or shares in drug development. So what is celiac disease? You all know it. It's just a summary. Of course, it's a very common intestinal inflammation due to gluten ingestion in up to 2% of most populations of the world. Gluten induces an inflammatory T-cell reaction in the small intestine, and the clinical picture is from a few symptoms to severe diarrhea and malabsorption. Many patients have so-called atypical, mainly abdominal symptoms, and complications are concomitant autoimmune diseases, and if long-term untreated, cancers that are otherwise rare, like small intestinal adenocarcinoma, intestinal T-cell lymphoma, or intermediate stages of refractory celiac disease type 2. And there is nowadays a pretty clear diagnosis by positive autoantibodies to the body's own enzyme, tissue transglutaminase, or TG2, and usually accompanied by classical duodenal histology, which you see on the right side of the slide, which is a complete villus atrophy compared to the normal villi on the right upper slide. The therapy appears simple, a strict gluten-free diet, but it's far from simple even nowadays. And another point is that about 30% of adult celiac patients have a concomitant autoimmune disease, mainly of the thyroid or type 1 diabetes, or some other more rare diseases, some of the rheumatoid form. So we know the major culprit, but is it the only major culprit, the gluten? So of course, first, we have many unsuspected sources of gluten in normal food, which is not declared gluten-free. It's not just the buns that you see here, but it's essentially what you see on the lower right side. All processed foods can contain traces, at least, of gluten. And that makes the gluten-free diet still difficult for people living a social life today or going to school, etc. So maintaining a gluten-free diet usually still is pretty difficult, and some patients have a perceived quality of life which is pretty low because they are afraid of social events and gluten contamination, for example, or they have even complaints still despite a strict gluten-free diet. And this percentage is up to 30% of people who still have complaints, not as before the gluten-free diet usually, so lesser complaints, but significant, and about another 30 or 40% overlapping with these symptomatic patients also have histological signs of at least mild intestinal inflammation due to celiac disease. So there might be very sensitive celiacs. That means that for many patients, we would need a supportive pharmacological therapy on top of the gluten-free diet. So this is not feasible that we have a gluten-free world, but there is a gluten-free museum in Amsterdam, at least online. You can see some funny pictures there, how the world without gluten and grains would look like. Maybe not so nice on the other hand, but it's everywhere. So what are the other factors? On the left side, you have, I'm not going at mechanisms here, a little bit later I will. So you have the gluten that is taken up by the intestinal wall, into the so-called lamina propria, where the immune system of the intestine sits, the biggest immune system of the body. And you have additional factors that can initiate celiac disease or worsen existing celiac disease. Of course, stress factors, like with essentially all diseases, can worsen inflammatory diseases. So there is really a foundation in basic science for that. There are microbial factors, so certain microbes might trigger or even protect from inflammation due to gluten ingestion, for example, as in inflammatory bowel disease. And there are additional dietary factors. So early high exposure to gluten in infancy. There is some other wheat proteins, the so-called AGI proteins, that can also promote, which are in grain or wheat anyhow, the response to gluten. And there is also other genes, minor genes, apart from the major genes, which are HLA DQ2, DQ8. Most know about that as predisposing genes that also contribute to a minor degree, but altogether significantly to celiac disease. So we know a lot about celiac disease immunopathogenesis, not just about the technology of toasters and gluten-containing bread. So that has led us to think about pharmacological therapies. So here we need a busy slide. So this is the epithelial lining. The epithelial cells are the green blocks sitting on the basement membrane, and below the basement membrane is connective tissue. But the immune system sits in the gut, and the dietary gluten is only incompletely digested by proteases. So the yellow balls, they get actively largely transported, like every foodstuff, to a minor extent into the lamina propria, and their immune cells sense this as dangerous or beneficial. So most foodstuffs are sensed as beneficial, and there the gut has a big task to do. But in celiac disease, this tolerance is broken, and the gluten peptides that are only incompletely digested, smaller fragments of the gluten protein, which is the major protein in wheat and related cereals, can react with the body's own enzyme, tissue transglutaminase, these rectangles here. And then these tissue transglutaminase can specifically react with the gluten and change the gluten's properties to become more immunogenic. And this cross-linked and, as we say, deamidated gluten can then be presented. That's a precondition for an immune reaction on antigen-presenting cells like macrophages and dendritic cells in the gut wall, in the mucosa, to T cells that are gluten-specific. Everybody has them. And here in the celiacs, these gluten-specific T cells can then expand and become rampant and cause havoc and tissue destruction by secretion of certain enzymes, by activating other cells that cause intestinal remodeling and the villus atrophy. They can also stimulate B cells, the immunoglobulin producing cells in the lamina propria wall, to produce antibodies to gluten, but much more specifically to the autoantigen transglutaminase that is involved in potentiating the immunogenicity of gluten. And these antibodies can then be measured in the blood in active celiac disease. The gluten can also indirectly activate other immune mechanisms that are so-called innate mechanisms of the immediate immune response, and that also contributes to the damage in the intestine. And also a component of that are the intraepithelial lymphocytes that get activated in celiac disease. So to date, we don't have an approved effective medication for celiac disease, apart from the gluten-free diet, which is still the best medication. There is development of so-called glutenases that can break down the gluten, that it cannot be presented in the gut anymore, cannot activate T cells anymore. There's drugs that can stabilize the so-called tight junctions, that not so much gluten can come into the lamina propria, can be taken up. There is nanoparticular tolerance. You inject nanoparticles that contain gluten, and they can produce an immunological tolerance against gluten. And there is developments, especially in our little company, in blocking molecules that block the DQ2, DQ8 molecules that are a necessary precondition but not sufficient for celiac disease. 30% of the population has it, but only a smaller quantity gets celiac disease. And there is, and I will talk a little bit more about this, the inhibition of the enzyme, the autoantigen tissue transglutaminase, that can block gliadin deamidation, and therefore potentiation of the immunogenicity. So what are the triggers of celiac disease? The gluten. We have, apart from the gluten, we have the genetic predisposition, necessary but not sufficient for celiac disease. If you don't have these genes, you don't get celiac disease. Autoimmunity is involved to the body's own enzyme, transglutaminase. And then there are certain other triggers that I've mentioned at the beginning. So this is present in 100% of the cases. So here we have a gluten peptide that is not normally degraded and enters the immune system of the gut. And what the enzyme, the autoantigen transglutaminase 2, is doing, it changes one amino acid residue. That's a one-letter code here. It's a glutamine to a glutamic acid, a Q to E. And this charged chain makes a better fit to the antigen-presenting molecule, in this case DQ2, which needs 9 amino acids of this one-letter code to fit into this antigen-binding groove from position 1 to 9. And there is a requirement for so-called hydrophobic or negatively charged amino acids. And what it does with a change in only this position, it causes a better fit in position 6. The other fits are more or less ideal, but not completely ideal. If they would be completely ideal, these T cells would be automatically eliminated by a self-regulatory mechanism. So that's autoimmunity, a good fit, but not an ideal fit. So it's improved with the negative charge from Q to E. And then the T cells with their T cell receptor can be activated and expand, proliferate. Okay, this inhibitor now is highly specific, and this is an X-ray structure for the enzyme tissue transglutaminase. So normally when this enzyme unfolds, it's short-term active and can react with other proteins and can do a so-called deamidation, what we have just seen in a protein chain. It can also do a cross-linking reaction, but it's only short-term active. And so what this inhibitor, small molecule, which is modeled after a tetrapeptide, it blocks the enzyme transglutaminase 2 irreversibly in this unfolded conformation and doesn't block any other related enzyme of the family of transglutaminase. So it's highly specific. And it can then block the gluten deamidation, which causes the better fit of the gluten to the finally T cells, and therefore can potentially block the immunogenic cascade. And it's orally available as a pill and mainly active in the gut, so it's not spread all over the body to a significant extent. And what has been done prior to the clinical validation is a phase 1A to B study or many cohorts of more than 100 patients to show safety of this drug. And the first study that was published in 2021 was in 160 volunteers with celiac disease in remission in 20 centers, and patients were divided into 4 groups. One group received a gluten cookie and a placebo, and the other ones received a gluten cookie and 3 doses of the drug once daily. And the primary endpoint was pre-biopsy, post-treatment biopsy for 6 weeks, changed in villocyte to crypt death. So villous atrophy, that was the hard endpoint. And that was published in 2021, as said. And as you can see here in the placebo group, from the baseline before drug treatment, villocyte to crypt death, on the right side, there is a significant drop in villocyte to crypt death, as you would expect with gluten exposure. So there's histological damage that can be quantified. And the drug dose-dependently annihilated this decrease basically of villocyte to crypt death as primary so-called study endpoint. And if you look at the intraepithelial lymphocytes, which increase in active celiac disease, this is on the right side, the placebo group. It decreases from baseline after 6 weeks of gluten challenge without drug treatment, whereas with drug treatment from left to right, with the highest drug dose, 100 milligram pill per day, it's completely abrogated. The same occurs with the slight decrease in so-called PROs, patient-related outcomes. It's a score for complaints due to activity of celiac disease. You can see here the red line during the treatment is the placebo group. It goes down. So the quality or the pain score, etc., gets worse. And in the follow-up of 4 weeks, it comes back to baseline. And all the treatment groups, the other colors, do better. Every group does significantly better than the placebo group. And finally, a so-called extra-intestinal side effect of intestinal inflammation, slight elevation of liver enzymes as a sign of slight liver inflammation gets completely abrogated by the drug treatment. So also this non-intestinal side effect. So in the last couple of slides, a very quick run, anti-leaky gut drugs, not very effective up to now. There is a promising drug. A study will likely, hopefully, start of next year with a small molecule that can tighten up tight junctions. A phase 2 study, oral glutenases. There is good glutenase that can degrade gluten, what the body cannot do completely. And still this enzyme ALF-003 still is going into clinical studies because it can further reduce gluten, but not completely, unfortunately. And this is a synthetic enzyme, KUMA-030, which is currently being tested in a phase 2 study. It's even more effective than the ALF-003. There is tolerizing gluten vaccination, so subcutaneous. A lot of years and a lot of money has been investigated, but finally the study failed as a prophylactic vaccination. Tolerizing nanoparticles that have to be given intravenously. There is 3 developments that are ongoing. Developments that target these nanoparticles to the spleen or to the liver. And we are just waiting what they do, if they can also maintain a tolerance, if they induce a tolerance successfully. There's an anti-interleukin 15 antibody, a new antibody by Calypso Biotech that is more effective than the prior one, which is going into a phase 2 study. But it's a systemic biological drug. And the same is true for an anti-OX40 ligand antibody. The study has just started by Sanofi. This is interesting because that addresses the so-called memory T cells, which are relevant in gluten memory responses. And then finally, a summary of the transglutaminase inhibitor. It addresses very specifically, much more than all the other drugs, the central pathomechanism of celiac disease. So it's not effective or in any other kind of inflammation of the gut. There is a mucosa active formulation, an oral pill. There is a dose-dependent prevention of histological damage and the complaint score. And a phase 2b clinical study in roughly 400 patients, 100 centers has just been finalized. We'll have the results by the end of this year. And these are patients without challenge. They have complaints and histological damage despite a gluten-free diet. So the real life scenario. There's another follow-up study which has started in May. These patients, in addition, in a smaller group of 92, 70 centers, has to be finalized quickly, receive a minimal dose of gluten per week for 12 weeks with gluten bars that contain minimal amounts, a 24th of the dose that they received in the first study. Okay, so very quickly, so non-responsive celiac disease that affects about 30% of the celiacs is a major indication. They still have complaints and minor inflammation. There are certain other indications where it might work, refractory celiac disease type 1, the non-malignant refractory celiac disease, which might be a high sensitivity to gluten traces. And then, of course, there's other more liberal indications where it's questionable if this drug would be approved, but it could still be useful if patients are eating out, etc., and are not sure if they might be exposed to minor amounts of gluten. They could take it as a standby medication. So this just as a summary. There's many collaborators in our studies. There's funding. We have a little own company developing DQ2, DQ8 inhibitors. And so thank you very much for your attention, and I hope you just got a little overview.
Well, thank you very much, Doctor. It's a pleasure that you are able to explain all these complicated issues in such a nice way. I know that you have a meeting in a few minutes, so I don't want to take more of your time, but be assured that you will have a very warm applause in Madrid when they will listen to this.
Thank you very much.
presentation.
It's always difficult to have, let's say, if you have a somewhat mixed auditorium, but it will mainly be also patients, but patients who know about the disease. So I think they will get some part of it. They will even know some part of it. So I think it's a little bit in a nutshell. So I hope it helps and it's good.
It will. Thank you so much.
Okay, you're very welcome. See you the next time.
Absolutely. Let's meet in person. Bye.
Okay, bye-bye.
Thank you.